Good afternoon, everyone. Thanks for joining us. We're going to give it a couple of minutes to fill the room here. Good afternoon again, everyone. We'll give it another minute to fill the room here. And we'll give it about 30 more seconds to fill the room. Good afternoon, everyone. Thank you again for joining us for our weekly Wednesday webinar series. Today's webinar is on anti-TFPI, an extended half-life recombinant factor VII for the treatment of people with hemophilia. My name is Beth. I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will post to our presenters after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, September 10th. I'm joined today by Dr. Michael Wang and Dr. Beth Warren, who are both from the University of Colorado. Dr. Warren, I'll turn it over to you to get us started.
Thanks. Welcome, everybody. Thanks for joining us. Dr. Wang and I today are going to talk about some upcoming treatments that will rebalance, have promised to rebalance coagulation a little bit that could be used to treat multiple bleeding disorders. So this is an exciting topic to us. Sorry, technical difficulty. There we go. Okay, this is my funding and conflicts of interest. I've been on a couple of advisory boards, and we have a lot of industry-sponsored studies going at our center. So I'm going to start off talking about some of the unmet needs in bleeding disorders, and then I'll talk about Marseptacog alpha, which is a long-acting subcutaneous factor VIIa, and then Michael will talk about Marstacimab, which is a TFPI inhibitor. So I think probably most people on this call know about hemophilia A and B, which is factor VIII or factor IX deficiency. There are a lot of different treatment options for those, a lot of different factor VIII and factor IX products, but it becomes more problematic if you develop inhibitors, which are antibodies against the factor. Those are fairly frequent. In hemophilia A, it's about 30% of patients with severe factor VIII deficiency, and in hemophilia B, it's about 5% of patients with severe factor IX deficiency. In hemophilia A, you treat with immune tolerance induction, which is frequent high dosing of factor VIII, and then also treat bleeding with bypassing agents, either recombinant factor VIIa or activated prothrombin complex concentrates. But there are some limitations to how those work. And then, of course, now many patients with inhibitors are on prophylaxis with imicizumab. In hemophilia B, it's less frequent, but it can be even more of a problem because patients with inhibitors also to factor IX often also have anaphylaxis. So it's really hard to do immune tolerance if you're going to get high dose factor IX and have anaphylaxis. So the main treatment is recombinant factor VIIa, in part because activated prothrombin complex concentrate has factor IX in it. So the other unmet need with not a whole lot of treatment options is factor VII deficiency. It's a lot less common than hemophilia A, for example. It's about 60 times less frequent. You can have a lot of different kinds of bleeding, intracranial, gastrointestinal, joint bleeding, and then also a lot of patients have problems with severe menstrual bleeding. It's not X-linked, it's autosomal recessive, so it affects, it has potential to affect women a little bit more often than hemophilia A and B. And then the severity differential is a little bit, the cutoffs are a little bit different for factor VII, but severe, where you have less than 10%, you have a risk of severe spontaneous bleeding. And then moderate and mild, the bleeding is a little bit more variable, but it can definitely be severe. And this is the hematologist's favorite coagulation cascade, or my very simplified version of it. And this is just showing, these are the clotting factors, which are, if you are not familiar with this, are very conveniently named by Roman numerals in the order that they were, in which they were discovered. So this is the extrinsic side, and this is the intrinsic side and extrinsic side, which is where factor 7 is. So this just activates factor 10 in a different way. And then the last unmet need that I'll talk about a little bit is Glanzmann's thrombocythemia, and that is a problem with platelets, specifically with this fibrinogen receptor. And platelets kind of get a bad rap as just they're not even full cells, they're just these little chunks of cells that just go around and plug holes. But actually, the platelets have a lot of intricacies that are that have to work together in order for platelets to work well. And this is a little diagram that I got from my mentor, Jorge de Paula, so when a platelet gets activated, it releases calcium, and that activates a lot of different things in the cell, like conformational change of this fibrinogen receptor, or the GP2B3A receptor, which we'll talk about in a little bit, which causes platelet aggregation. It also, activation of platelets causes platelet spreading, and then release of granules that cause activation of other platelets, and also generation of thrombin, and then also externalization of phosphatidylserine. So this gives a negative charge for all the different clotting factors to act on. So a lot of different intricate things happening in a platelet. So in Glanzmann's, your fibrinogen is missing or largely missing. And that is a huge problem because platelet aggregation is really critical. So patients who have Glanzmann's thrombocythemia have a lot of bleeding. In factor 8 and factor 9 deficiency, if you don't have an inhibitor, you can give factor 8 or factor 9. But in Glanzmann's, you can transfuse platelets, but there's a big worry that your immune system will attack this fibrinogen receptor so that whatever platelets you transfuse will not work. And it's really hard to stop bleeding when you don't have that as a tool. So another option that is used is recombinant factor 7A. So that makes a lot of thrombin to activate the platelets, and then has some other uses that I'll go into in a second. So all of those have in common that you can treat them with factor 7. So I wanted to go into a little bit what factor 7 can do. I talked a little bit about my favorite coagulation cascade with the Roman numerals. So factor 7 can so the main goal of the coagulation cascade is to make thrombin, which activates platelets and also has a feed forward mechanism on the rest of the coagulation cascade. And then also to make fibrin, which are those nice strands that you see if you look at a picture of a clot close up. And then you don't want, so the two ways to activate it, either through this pathway that includes factor 8 and 9, or else through factor 7. And those activate factor 10, which then generate thrombin and fibrin. But you don't want to just, if you start clotting, you don't want to just keep on clotting and keep on clotting. So there are also some negative feedback loops, proteins C and S, and those inhibit activated factor 8, and then also inhibit the factor 5, factor 10, the activated factor 5 and 10 complex. So factor 7 is involved with a lot of these aspects of this cascade. So with tissue factor, it can activate factor 10. It can also activate factor 9 a little bit. And then even if you don't have tissue factor, you can generate factor 7 can be used to generate thrombin on the surface of a platelet. And then there's this, it's sort of a newer understanding of the actions of factor 7 is this endothelial protein C receptor and how it reacts with activated factor 7. So this is the same protein C as this protein C right here. So the most famous job of the EPCR is to bind and activate protein C. So then that revs up this negative feedback loop. But the other jobs that it does is it brings factor 7A into extravascular tissue, so it can actually be stored there for a couple of days. It takes factor 7A into megakaryocytes, which are the platelet precursors that live in the bone marrow. And then high dose factor 7A can actually displace protein C from the EPCR so that less protein C is activated, so you have less negative feedback. And this is a really great article by Dr. Meeks and Lysager that summarizes these different functions, if you want to know more. So there are 2 available factor 7A products on the market now, or approved in the US. by the FDA now, rFVII, which is also called Eptacog alpha, and that's approved for congenital hemophilia A and B with inhibitors, for acquired hemophilia, congenital factor VII deficiency, and then also for Glanzmann's thrombocythemia. It is only IV, and its plasma half-life is around 3 hours, and you need to dose fairly frequently if you're still having bleeding, dosing every 2 to 6 hours. And then 7-Fact is a newer product. It's Eptacog beta. It's only approved so far for congenital hemophilia A and B with inhibitors. It is IV also. It has a little bit of a shorter plasma half-life, but that is possibly because there's a greater affinity for the EPCR, and so it's possible that it just gets kind of sucked into the extravascular tissues a little bit faster. Suck is not the most scientific word there, but you know what I mean. And then it's dosed every 3 to 9 hours. So these are great and they're very useful, but they can only be given IV, and then they have pretty short half-lives. So there have been several different attempts to get a subcutaneous version of factor VIIa, or to have a longer lasting one, and there have been several lessons learned from that. The first problem with previous versions of factor VIIa given subcutaneously is that it's really hard to get the levels high enough that they can actually treat bleeding. And then the second problem is that there have been a couple of versions that have had real problems with immunogenicity, so that have caused antibodies and inhibitors against the drug. So there are a couple of things that Marseptacog has done differently to try to optimize those things. So one is, there are 2 amino acid changes that increase absorption through the skin or through the subcutaneous tissue, and then also keep it from being broken down as quickly. And then there are 2 amino acids that have been switched that make it more procoagulant, to make it a little bit stronger of a reaction against factor X. And there are a lot of different ways to measure that, either in a test tube or in animals. And the conclusion is that it is about 5 to 10 times more activity against to activate factor X than Eptacog alpha. And then the other thing is that we believe that we know the exact amino acids that promoted that immunogenicity, and this Marseptacog, or the abbreviation is MarsAA, does not have those changes. So we are hoping that this will finally be a great product for people, but I'll go into the clinical trials in a little bit. The half-life when given IV is about 3.5 hours, and then subcutaneous, the half-life is about 17 hours. So there have been 3 completed clinical trials and then 2 that are ongoing. So I'll go through the completed ones first. So the first was a phase 1A study, just looking at single dosing of IV. It was before it was called Marseptacog, but now Marseptacog in adults with hemophilia A or B. And the conclusion of that was basically that it was safe. And then phase 1, I'll go into the details a little bit more, but this was looking at the pharmacokinetics of MAA102. This is another phase 1. So these are the early phase with a small number of people looking at the pharmacokinetics. And this was looking at both IV and subcutaneous dosing, again, in hemophilia A or B with or without inhibitors. And then the other phase 2 studies, that's looking more at efficacy and safety, and also expanding the pharmacokinetic studies. This study looked at prophylaxis of daily subcutaneous Marseptacog in patients with hemophilia with inhibitors. So I'll go over those last 2 in a little bit more detail. So these are the summary results of MAA102. This was presented by Dr. Newman at ISTH, and then it sounds like the actual publication is hopefully going to be accepted soon. But they had several different doses, and these are the doses that kind of worked out the best. So 60 mics per kg, and then that was either once or dosed twice, 3 hours apart, or dosed three times 3 hours apart. And the target goal is 24 to 120 nanograms per mil. That is derived from the levels you need for continuous infusion of rFVII, with the assumption that Marseptacog is 5 times more potent based on a bunch of other studies. So you can see that within 3 hours, basically all of these doses were in the target range. And for this 120 mics per kilo dose, it was in the target range earlier. And then all the 60 mics per kilo one dose was in the target range until 18 hours. And then all the other doses were in the system beyond really 30 hours. So that in the target window beyond 30 hours. So that is very promising. There were 11 participants and then 1 withdrew before the subcutaneous part of the dosing. And the kind of theory behind this is that as the subcutaneous, you have like a subcutaneous store, so that as your factor VII is getting used up or taken into the extravascular space, is sort of also getting released from the subcutaneous tissue. And that can give it this longer half-life. So for safety, there were a few adverse events that were not felt to be related to Mars-A, like upset stomach and that kind of thing. The only ones found to be related were injection sites reactions, and those were minor in 8 of 153 injections. There were no thromboses and then also no anti-drug antibodies. So this is the phase 2 study, or the MA201, which is a phase 2 looking at prophylaxis of Marseptacog in patients with hemophilia and inhibitors. And so there was this initial pharmacokinetic portion, and then they started the treatment portion. So in this section, there was 30 mics per kilo given daily. They reached steady state after about 5 days, and then monitored bleeding rates in the next 50 days. So then if they had any spontaneous bleeding, then they advanced to the next dose. So there were, which was 60 mics per kilo. So 2 people ended up needing to go to this next dose, and then no one needed to go higher than that. And this was a group with a pretty high baseline bleeding rate. So these are the take-home results from this study. There were the initial, prior to Marseptacog prophylaxis, this is the ABR 19.8 bleeds per year in the 6 months. And then after they were on Marseptacog prophylaxis at their target level, this was the bleed rate, so 1.6 per year. And then this is a metric that not all studies use, but I think is a really meaningful one. It's proportion of days with bleeding. So 12.3% of days had bleeding prior to the Marseptacog prophylaxis, and then after prophylaxis when they were at their target, only 0.8% of days had bleeding. So that's has potential to have a huge impact on quality of life. And there were 9 people who completed the study. So there were, again, no thrombotic events and no anti-drug antibodies. There was one fatal serious adverse event that was unrelated to Marseptacog, but it was still really sad. So there was a patient with an intracerebral hemorrhage related to a hypertensive crisis. So blood pressure got really, really high and had hemorrhage at that point. And he unfortunately had not been taking his hypertension medications. So very sad and important to talk about, but not felt to be related to Mars-A, in part because nobody else in the study had any changes in their blood pressure. And then there were 6 of 517 injections had injection site reactions. All right, so there are 2 studies that are in progress that are recruiting now. One is MAA304. That's a phase 3 study. So those are the ones that are right before submitting to the FDA. And this is in adolescents and adults with hemophilia A or B with inhibitors. And that's comparing Marseptacog treatment to standard of care with recombinant factor VIIa or activated prothrombin complex concentrates. And then this one is just open in our center, and I'm very excited about it because it enrolls people who don't have a lot of other treatment options. And that is looking at adults and adolescents with factor VII deficiency, Glanzmann's thrombocythemia, or hemophilia A with inhibitors who are also on emicizumab prophylaxis. And we'll look at the safety of the pharmacokinetics and also looking at the safety and efficacy of treating bleeds on demand. So we'll be anxious to see how those turn out. So in conclusion, there have been 3 completed studies and 47 subjects have received 690 doses of Marseptacog. And so far it's been, seems like it's pretty darn safe. And then I am hopeful that these can be used for treatment and prevention of bleeds, especially in some underserved, some populations that don't have a lot of other treatment options. Most all the trials now are for treatment of bleeding, but hopefully in the future there could be some future trials that also look at prevention of bleeding. And that's all I have on Marseptacog, and I'll hand it over to you, Mike. Once I can figure out how to stop sharing my screen. Okay, there we go.
Great, thank you, Beth.
So while we're waiting for Dr. Wang to share his screen, Beth, we do have a couple of questions that have come in. So maybe we'll go to that if you're both okay with that.
Sure.
Great.
Great.
First question that comes in, Dr. Warren, what do you mean by rebalancing the coagulation system?
I guess Mike will go into more of this, but so the unmet needs that I was talking about, it's hard to specifically replace what's missing. So it's these treatments focus on targeting another part of the coagulation cascade. I guess that's not really true for factor VII deficiency since you're replacing factor VII, but and then Mike is talking about TFPI, which rebalances in a different way.
Okay. And can I sneak one more question in here?
Yep.
And then we can save the rest to the end here. The next question is, I've never heard about the EPCR before. Are there people who are deficient in this receptor, and what does their disease look like, or what does their disease look like?
You know, I have not heard of anybody with EPCR deficiency, but I don't actually know if people are looking for it.
Right, I mean, that would seemingly be really, really dangerous, right? Like you wouldn't have, it'd be like protein C deficiency.
Okay.
Then I would think you'd have clotting problems.
Mm-hmm.
Yep. I have not heard of it clinically, but I'm not sure if anybody is looking for. I have not personally ever looked for it.
Okay, great. There are some more questions that came in. We'll save them to the end though, and we'll let Dr. Wang take over here.
Great, Brett, thanks, and Len, thanks for the invitation. I think with all of the innovations that have been occurring within the bleeding disorder space, it's very nice to kind of go down the alphabet and do the M's today, I guess. And so today I'm going to talk about Marstacimab. And Marstacimab is a monoclonal antibody, fully humanized, that targets the K2 domain of tissue factor pathway inhibitor, otherwise known as TFPI. And to kind of bring in the question previously asked, when we are talking about rebalancing, sometimes we are talking with the idea that, for instance, if you have hemophilia A and you viewed yourself like this, that you may be tipped towards a bleeding phenotype or more bleeding. And for instance, if you have a gene that has a deficiency that causes you clotting, you could be like this. And what we're doing is we're trying to take people who are in a bleeding phenotype and move them more like this. And I think some of the difficulty when we discuss this is that if we're on a playing field like this, we're not necessarily doing this. We may be doing this lower, we may be doing this higher, and it may be in 3 dimensions, right? And that's where I think that this molecule will highlight the difficulties in understanding what rebalancing really is, specifically in the context that this molecule and its effects are very difficult to measure. So these are just cartoons of TFPI on the left, and then TFPI bound to Marstacimab. So these are my conflicts of interests. I sent a number of advisory boards, and we had both the emicizumab trial and the phase 1b Marstacimab trial open here. So again, Beth went through this slide prior, and so I will kind of focus really at the bottom, which is highlighted in red, and that's hemophilia B with inhibitors. Which is not to say that hemophilia B without inhibitors doesn't have unmet needs. It's just acknowledging the fact that extended half-life factors for hemophilia B have been much more effective than they have been for hemophilia A. But again, for hemophilia B, this really accounts with inhibitors, accounts for about 5% of patients with severe factor IX deficiency. These inhibitors sometimes come with anaphylaxis, which very limits which you can use for bleeding to really recombinant 7A at the moment, as immune tolerance can be very, very, very difficult to achieve or to even embark on. So therapies to rebalance hemostasis. And so what we've seen recently, and it was really reported in 2017 in the HAVEN-1 trial, are factor VIII bispecific antibodies. And the example now of an approved one is emicizumab, and currently in trial is another one that has higher affinity for activated factor IX, which is MIM8. There are medications that look to decrease the amount of antithrombin. And so antithrombin interference RNA therapy is really in phase 3 trial, and the medication name for that is fitusiran. And what we'll talk about today are monoclonal antibodies directed against tissue factor pathway inhibitor. And to date, there have been 3 monoclonal antibodies tried. There was an early trial of an aptamer that failed. But in order, there is, I will never be able to say the first one, it's bifovazimab. And this clinical trial has been terminated because of thrombosis. One that is more familiar to patients that I know is concizumab, and that's currently enrolling in a phase 3 trial. There are two portions of that, and they started enrolling in the fall of 2019. And what we'll talk about today is marstacimab, which is also in a phase 3 trial. It's called the BASIS trial, and that's its trial number if you'd like to look up more details on it. And it enrolled its first patient in November of 2020. So this is very, very early in enrollment. The BASIS trial is really aimed to recruit 145 male adolescents and adults ages 12 to 74 who have severe hemophilia A or B with or without inhibitors. And they're looking to get 20% of participants to be adolescents. And so the need for prophylaxis in people with hemophilia and inhibitors has been recognized ever since we've started to treat hemophilia with factor concentrates or with factor replacement. In 2011, Dr. Lessinger reported the effective use of prophylaxis, and this was with FIBA in patients with factor VIII or factor IX inhibitors. And what this one figure tries to describe is in bleeding events for people who were on demand, and then when they switch to prophylaxis, how their number of bleeding events dramatically decreased. And subsequently, if you look to the right, these are the results of the HAVEN-1 trial. And HAVEN-1 was hemophilia A patients with a factor VIII inhibitor. And again, it showed a very robust protection against bleeding. And so you can see that the annualized bleeding rates of patients who are on emicizumab prophylaxis were dramatically less, group A than B. And these graphs conveniently are somewhat equally depicted, which means to say that in this panel and this panel, it represents patients who were on previous prophylaxis and showing that that when they were on demand, they had much more bleeding, and when they returned to prophylaxis, they were better, and the same thing over here. And so we know that prophylaxis is achievable, but it's very difficult to do. So back to TFPI. And so what is it? So TFPI is a negative regulator of coagulation. And really, if you can focus on the function, what it does is that the K2 domain of TFPI, which is this little ball, it's called a Kunitz domain, it binds it binds and inactivates factor 10A. And then when that is bound, it will subsequently, through the K1 domain, bind tissue factor 7A. And so it forms this pretty large inhibitory complex. And so early studies showed that actually bleeding in hemophilia requires not only the absence of factor 8 or factor 9, but this group showed that it also required the presence of TFPI. And why is that important? So on the left here, you can see that in the presence of TFPI, again, it functions to inhibit factor 10A and then also to inhibit factor 7A. So it really controls this pathway. Sorry about that. This pathway there. In panel B, what you can see is that sorry about that. Each time I touch that, it is that when you have TFPI here, it allows really the activation of the extrinsic pathway. To answer kind of another question, there really hasn't been a severe deficiency of TFPI described in a person yet. And in part, it's because it's very hard to measure, and it's because it's very dynamic and complex. It exists in plasma, in platelets, and also in endothelial cells. But the form in plasma is what we believe is the physiologically active anticoagulant. So to start with, this molecule, then known as PF06741086 or marstacimab, was shown that this monoclonal antibody can bind TFPI and promote coagulation activity. So in a mouse tail clip model, they would infuse mice with saline and then clip the tail and then measure the amount of blood loss. And so you can see in the gray bar that's about 600 microliters. Then these mice were infused with a single dose of marstacimab, and at certain time points, for instance, 1/2 of an hour, 24 hours, or 96 hours, etc., they could show that the bleeding was actually much reduced. And the effect really lasted to about 168 hours. And so based on this information in 3 studies, it showed that one, that this antibody was specific for its target, and that a single dose could enhance thrombin generation and decrease bleeding. And then it could do that in this mouse model. So ultimately, this led to the data that I will discuss today. The phase 1A study was in healthy volunteers to show that it was safe first in healthy volunteers. So this is a phase 1B2 study that really looked at the safety, tolerability, and pharmacokinetics and dynamics of this molecule, marstacimab, in patients with severe hemophilia A and B. And as disclosure, we were participants in that study. So this study had an interesting design, in part because it was trying to find the appropriate dose of marstacimab, and it used some previous data that suggested that a once-a-week dose would be sufficient. And so it had multiple ascending dose levels, and the treatment period was for 3 months. And most importantly, part of the inclusion criteria were that patients and subjects were screened for prothrombotic conditions, meaning that these patients couldn't have a mutation in the prothrombin gene, factor V Leiden mutation, protein CS deficiency, or antithrombin deficiency. And that was for patient safety. And what is highlighted here is the arm that was ultimately chosen for the phase 3 trial, which was a 300 milligram sub-Q loading dose, followed by 150 milligrams sub-Q once a week. And we'll look at some of that data next. So this was a global study, and the reason I bring this slide up is because there were really only two subjects enrolled in the United States, and because of that, I feel that this molecule is much less known to the U.S. bleeding disorder community. The vast majority of the patients, again, were enrolled in South America and in South Africa. So this is a quick look at the marstacimab pharmacokinetics, and I will specifically point out the lowest bar, sorry about that, which is the dose that was actually chosen for the clinical trial, which was the STARS, and that was the 300 milligrams sub-Q loading dose with 150 milligrams sub-Q Q week. And they looked at a lot of pharmacodynamics, and this is where I think we start to see the difficulty of understanding this balance or this rebalancing question. So in the top left, you can see that when you expose a patient to the monoclonal antibody, the actual amount of tissue factor pathway inhibitor that you can assay increases. And that's because the monoclonal antibody binds the TFPI, and then it's not degraded in its usual fashion, so it looks like it's accumulating. When you look at the next panel, you can see that the peak thrombin generation was enhanced in these patients after they received it. But then you can see on the panels next to that, the PF 1.2 and the D dimer, those were also elevated. And so these are things that I think have concerns some people about these rebalancing therapies in general. And for this drug, this is how all of those markers look. For safety and tolerability, in all of the cohorts, there were AEs, there were no treatment-related SAEs. The SAEs were acute appendicitis, cholelithiasis, a tooth socket hemorrhage, and then a person that was assaulted. There were 4 anti-drug antibody samples from 3 subjects that did not affect the PK, PD, or safety, so there were no neutralizing antibodies detected, and there were no thrombotic events. And here's where I think where we can see the 3-month prophylaxis effect. And so this is Marstacimab prophylaxis, the reported annualized bleeding rate, the median pre-study versus during treatment using Marstacimab in this trial. And if you look at these patients, so if you look at the far left, that was a person who had received a dose of 300 milligrams sub-Q week. The next patient was a patient that actually received what turned out to be the phase 3 treatment regimen, which was a 300 milligram sub-Q loading dose followed by 150 milligrams sub-Q weekly. And what I think is pretty clear on this diagram is that pre-treatment, there was a substantial amount of bleeding. And then while these patients were on therapy, that bleeding was decreased. And of note, when people ask, well, how was that dose ultimately chosen, this load plus the 150 milligrams sub-Q, it was chosen as a dose that was lower, lower in the escalation, so potentially safer. But it also showed that it still maintained good bleed protection. And that would be the bar that is purple and so 15 bleeds to 0. So these are the summaries and the conclusions of this phase 1b/2 study. Of note, so there weren't treatment-related SAEs. There were no thrombotic adverse events. They state no clinically significant changes in coagulation labs. I think that some people would challenge that, and I could just see the chat box blow up, because we don't know what a significant change with an inhibitor for TFPI really is. We don't have enough experience with that, I believe. And then there was a reduction in ABR of greater than 85% observed in hemophilia A and B subjects with and without inhibitors at all doses. And so what they concluded was that Marstacimab had an acceptable safety and tolerability, that the pharmacodynamic effects were overlapping, but it had a very wide therapeutic index, and hence they could choose a lower dose. It had a clinically meaningful reduction in the annualized bleed rate across all dose levels. And so these supported the application and then the initiation of a phase 3 trial, the BASIS trial, again, with its first patient that was enrolled in November of 2020. So advantages and disadvantages of anti-TFPI therapy and unmet needs. So I think there are some challenges, and I put them first here just to get them out there, and because I assume that this is where many questions may arise. So first is that 2 of the 3 anti-TFPI monoclonal antibodies have shown drug-related thrombosis, with one of the studies consequently terminated. None of the thrombotic events was predictable with the current monitoring tools, meaning that all of those tests I showed you didn't really pick out which patients were going to have a thrombosis, and none appeared to correlate with known coagulation parameters. All 3 anti-TFPIs, again, undergo this target-mediated drug disposition. So this would impact the formulation of dosing regimens for these therapies. And so, for instance, the drug concizumab is given as a once daily dose, whereas Marstacimab is a once weekly dose. Both are sub-Q. And there's no assay to measure the TFPI as the actual physiological levels are very low, which makes the monitoring of the impact quite a challenge. And when you get those higher levels, it is very unclear if we understand exactly if there's a threshold effect or a point, a safety or efficacy level. Again, the advantages then of these therapies are that 2 of the 3 studies showed acceptable safety and good phase 2 data in terms of bleed prevention. They are both bioavailable when administered subcutaneously. So it would offer yet another option for a subcutaneously delivered medication. And then finally, the stable pharmacokinetics and the ability to prevent bleeds in hemophilia A or B patients with and without inhibitors really does address kind of this large unmet need, mainly in my eyes, of hemophilia B patients who are burdened by a factor IX inhibitor. So with that, I would take any questions, as will Beth, about either of these molecules. Thank you.
Great. Thanks, Dr. Wang. Thanks, Dr. Warren. Since you just mentioned this, Dr. Wang, I'm going to ask this question to you that came in. This is, you did not address Marstacimab in detail. I understand those trials were halted due to thrombotic concerns. Have they restarted enrolling?
We do not have those trials open here. I do believe that they are restarted. Len, do you know that?
I do not.
Yeah. Sorry about that. I was so focused on Marstacimab, but you're right. Those were halted for thrombotic concerns.
Okay, great. Next question, Dr. Warren. This came in earlier. It says the use of rFVII is sometimes challenging when treating active bleeding. Have you found 7-FAC to be more effective in patients with inhibitors?
To be honest, I have not used 7-FAC personally. It looks good on paper, but we just haven't had people who wanted to switch over. Have you, Mike?
Yeah, so we had the 7-FAC clinical trials here and enrolled, I don't. Yeah, I mean, it would be purely anecdotal. All I can say is that it effectively stopped bleeding.
Great.
In our personal use.
Great. Dr. Warren, this question came in right at the tail end here. It says, or I'm sorry, Dr. Wang, this question came at the tail end of your presentation. They wanted to ask, when do you anticipate the results from phase 3 of this study, or where are things today?
That's a really great question. As with many trials, they were really, enrollment was decimated because of the pandemic. And so I think for any of these trials, I wouldn't anticipate real phase 3 data with a large enough cohort to have analyzable data until at least 2023, 24, I would think.
And I don't want to butcher this, Dr. Warren, but I'm gonna attempt here anyway. Because of the changes in the structures of, is it Marseptacog? Is this likely to cause anti-drug antibodies?
So the thought is that it is not, because it is not at a location that have caused anti-drug antibodies in other drugs, but they are being extremely cautious. They're measuring anti-drug antibodies in, I think, like 4 different ways to make sure that does not happen. So hopefully not, but always a possibility when you're changing molecules.
And along those same lines, because Marseptacog is 5 times more potent than rFVII, is it likely to cause more blood clots?
That is also hopefully not. I think that is something that is being watched for very closely in these clinical trials. But the hope is that it's just you don't need to have as much absorbed subcutaneously to be effective. But that is something that is being closely monitored and has not been seen so far.
Okay. We've got a couple more questions that came in. I think we've got some time here. Have you used 7-FAC in patients with Glanzmann's? If so, what situation, dose, and frequency? And do you know of any published case studies related to this issue?
I have not. have you used it, Mike?
No, I haven't. I guess to answer that, no. The dose of Eptacog alpha for Glanzmann's is the package insert dose, which is 90 mics per kilo per dose. For Southern Fact, that would be 75 mics per kilo per dose. And so I don't have any experience trying to use that on a Glanzmann's patient myself here. But would that be the choice? The limitation of their formulary, for instance, I've seen that come up recently. That would be the dose I would choose.
Great. We've got one last question that's come in. Is it true that O blood types produce around 25% less clotting factor overall?
So my understanding of the mechanism for blood type O is that you have increased clearance of von factor, but I don't think it's a straightforward 25%. I think it's generally a little bit less, and generally a little bit more variable than that.
Yeah, and I don't think it applies to other procoagulants either.
Oh, right, yeah, von factor and factor VIII maybe a little bit lower.
And another question came in. This is actually a really great question, and I'll ask this to both of you. What do you think the role for these new molecules are in the era of Hemlibra?
Right. So I can hop in there. So I think that for an anti-TFPI, I again think that the role is for hemophilia B patients. And so, for instance, if you have a hemophilia B patient who does not have an inhibitor, but has, let's say, IV access issues, this may be, an alternative. If you have a hemophilia B patient who has an inhibitor, really the only treatment and prophylaxis that patient has at the moment is recombinant 7A. And if they don't have a factor 9 allergy, they could use FIBA. And so I think it gives those inhibitor patients really some form of what looks like potentially effective prophylaxis.
Okay, great. And we have another question that came in. Why were so few people enrolled in the U.S. into the Marstacimab study?
That's a good question. I think so I do not know how Pfizer went after sites in particular for that. I just know that there weren't a lot of US sites open at that time. I think there are probably a number of reasons that could have happened, but I could only speculate.
Okay, great. I don't see any more questions coming in here. Dr. Valentino, is there anything that you wanted to add at all?
No, I think it's it's exciting to see the continued innovation in the field. These molecules have been a long time in the coming, and it would be great to see these trials come to conclusions so that we really know what the place for these molecules is for people who have hemophilia A or B with or without inhibitors, as well as these other rare coagulation disorders. I think that's where the real benefit potentially is for some of these molecules, is in areas, like Dr. Warren talked about in factor VII deficiency, where there isn't great therapies. There's 2 agents that are available, but the dosing still remains somewhat challenging. So there may be opportunities in factor VII deficiency, or more importantly, potentially in Glanzmann thrombasthenia.
Great. Well, Dr. Warren, Dr. Wang, we'd like to thank you for taking the time to join us this afternoon. We appreciate your time and expertise, and thank you for taking the time out today.
Great. Thanks for the invitation.
Thank you, everybody.
Thank you. Thanks.
Please
Have a good day, everybody.
Have a great day.
take care, everyone. Thank you.